Learning outcomes. After studying this module, you shall be able to know what sleep is and its various stages, identify and describe various types of sleep-wake disorders, evaluate methods used to treat sleep-wake disorders, and to learn steps to develop more adaptive sleep habits. Now we come to the introduction of this chapter. We spend about 1/3 of our lives asleep. That means most of us sleep nearly 3,000 hours per year. For many of us, sleep is energizing, both mentally and physically. Good sleep is necessary for optimal health and can affect hormone levels, mood, and weight. Sleep is a biological function that remains in some ways a mystery. We know that sleep is restorative and that most of us need 7 or more hours of sleep a night to function at our best. Sleep disorders or disturbances can cause our sleep to be disturbed. Disturbed sleep includes the inability to fall asleep, the inability to go back to sleep, and frequent waking up during the night. Sleep disorders can make you feel tired, fatigued, and irritable, making it difficult for you to concentrate during the day. Most people have experienced sleep disturbances at some point in their lives. Anyone at any age can develop sleep disorder or disturbance. Now we try to understand sleep and its disorders. Sleep and wakefulness are fundamental behavioral and neurobiological states that characterize all higher animals, including human beings. Sleep is a naturally recurring state characterized by an alerted consciousness, relatively inhibited sensory activity, and inhibition of nearly all voluntary muscles. It is distinguished from the wakefulness by a decreased ability to react to stimuli, and it is more easily reversible than being in hibernation or a coma. In mammals and birds, sleep is divided into two broad types, rapid eye movement and non-rapid eye movement sleep. Each type has a distinct set of physiological and neurological features associated with it. REM sleep or REM sleep is associated with movement of eyes rapidly under the eyelids and capability of dreaming, whereas non-REM sleep is much deeper, more restful kind of sleep. The American Academy of Sleep Medicines, that is AASM, divides sleep into 4 stages. Stage 1. This is the first stage that involves a state of transition from wakefulness to sleep, characterized by relatively rapid low voltage brain waves. Stage 2. This stage involves a sleep deeper than that of stage 1, characterized by a slower, more regular wave pattern along with momentary interruption of sleep spindles. Stage 3. The sleep in this stage is characterized by slow brain waves with greater peaks and valleys in the wave patterns. Stage 4. This is the deepest stage of sleep during which we are least responsive to outside stimulation. Now we come to understand somnopathy or sleep disorders. A sleep disorder or somnopathy is a medical disorder of the sleep patterns of person or animal. According to the American Psychiatric Association, sleep disorders are major disturbances of normal sleep patterns that lead to distress and disrupt functioning during the day. Not only are sleep disorders extremely common, affecting virtually everyone at some point in their lives, but they can also lead to serious stress and other health consequences. Sleep problems of sufficient severity and frequency that they lead to significant personal distress or impaired functioning in social, occupational, or other roles are classified in DSM system as sleep-wake disorders. The term sleep-wake disorders replaces the earlier diagnostic term sleep disorders, so as to underscore the fact that these disorders involve problems occurring during sleep or at the threshold between sleep and wakefulness. There are more than 70 different sleep disorders which are generally classified into one of the 2 categories: Dyssomnia, Insomnia, Hypersomnia, Narcolepsy, breathing related disorders, and Circadian rhythm sleep disorders. The next category we have is Parasomnias, which includes sleep terror, RBD, sleep waking and nightmare disorder. The clearest and most comprehensive picture of your sleep habits can be determined only by a polysomnographic evaluation. Etiology. The DSM-4TR recognizes 4 general types of sleep disorders on the basis of the causes underlying them. Number 1, sleep disorders related to another mental disorder are sleep disturbances that are directly attributable to psychological disorders. Sleep disturbances occur in many mental disorders. In particular, insomnia is a symptom of unipolar depression and co-occurs at high rates with the other mental disorders including bipolar disorder, schizophrenia, attention deficit hyperactivity disorder, the anxiety disorders and substance use. The symptoms of these disorders such as anxiety can make it difficult to sleep. Next we have is sleep disorders due to general medical conditions. These are the disturbances that result from the physiological effects of a medical condition. Many medical conditions can disturb sleep, including degenerative neurological illnesses such as Parkinson's disease, cerebrovascular disease including strokes, endocrine conditions such as hypo or hypothyroidism, viral and bacterial infections such as viral encephalitis, pulmonary diseases such as chronic bronchitis, and pain from musculoskeletal diseases such as rheumatoid arthritis or fibromyalgia. Next is substance-induced sleep disorders. These are the disturbances due to the use of substances, including prescription medication and non-prescription substances. Then comes primary sleep disorders. These are the sleep disorders that are not due to a general medical condition or substance use and cause significant impairment in functioning to be diagnosed. They include dyssomnias or parasomnias. Now we'll discuss dyssomnia in detail. Dyssomnias involve difficulties in getting enough sleep, problems with sleeping when you want to, and complaints about the quality of sleep. It is characterized by either hypersomnia or insomnia. Dyssomnia can be further subdivided into primary insomnia, primary hypersomnia, narcolepsy, breathing-related sleep disorders, and circadian rhythm sleep disorder. So first we will discuss insomnia disorder, formerly called primary insomnia. The term insomnia derives from the Latin in, meaning not or without, and somnus, meaning sleep. Thus, insomnia is characterized by inability to fall asleep or to stay asleep as long as desired. A diagnosis of insomnia disorder requires that the problem has been present for at least 3 months and that it occurs at least 3 nights per week. Insomnia is often a symptom of a mood disorder or underlying health condition. According to DSM-4TR, the diagnostic criteria for primary insomnia is as follows. Number 1. A predominant complaint is difficulty initiating or maintaining sleep or non-restorative sleep for at least 1 month. 2. The sleep disturbances cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Number 3. The sleep disturbance does not occur exclusively during the course of narcolepsy, breathing-related sleep disorder, circadian rhythm sleep disorder, or a parasomnia. Number 4. The disturbance does not occur exclusively during the course of another mental disorder, which may include major depressive disorder, generalized anxiety disorder, or delirium, etc. Number 5. The disturbance is not due to the direct physiological effect of a substance or a general medical condition. So next category we have is hypersomnolence disorder, which was formerly called the primary hypersomnia, which is sometimes referred to as sleep drunkenness. It is a pattern of excessive sleepiness during daytime hours, occurring at least 3 days a week for a period of at least 3 months. According to DSM-4TR, the diagnostic criteria for primary hypersomnia is as follows. Number 1. A predominant complaint is excessive sleepiness for at least 1 month, as evidenced by either prolonged sleep episodes or daytime sleep episodes that occur almost daily. Number 2. The excessive sleepiness causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. Number 3. The excessive sleepiness is not better accounted by insomnia and does not occur exclusively during the course of another sleep disorder, and cannot be accounted for by an inadequate amount of sleep. Number 4. The disturbance does not occur exclusively during the course of another mental disorder. Number 5. The disturbance is not due to the direct physiological effects of substance or a general medical condition. So next disorder under the same category is breathing related sleep disorder. People whose breathing is interrupted during their sleep experience numerous brief arousals throughout the night and do not feel rested. For all of us, the muscles in upper airway relax during sleep, constricting the passageway somewhat and making breathing a little more difficult. For some, unfortunately, breathing is constricted to a great deal and may be labored. Or in the extreme, there may be short periods, maybe from 10 to 30 seconds, when they stop breathing altogether, which is called sleep apnea. Other signs that a person has breathing difficulties are heavy sweating during the night, morning headaches, and episodes of falling asleep during the day, with no resulting feeling of being rested. There are 3 types of apnea, each with different causes, daytime complaints, and treatment: obstructive, central, and mixed sleep apnea. According to DSM-4TR, the diagnostic criteria for breathing-related sleep disorders are as follows. A. Sleep disruption leading to excessive sleepiness or insomnia that is judged to be due to a sleep-related breathing condition. B. The disturbance is not better accounted for by another mental disorder and is not due to the direct physiological effects of a substance or another general medical condition. Then another disorder under the same category is narcolepsy. The word narcolepsy is derived from the Greek word narke, means stupor, and lepsis, meaning an attack. People with narcolepsy experience an irresistible need to sleep or sudden sleep attacks or naps occurring at least 3 times a week for the past 3 months. This is accompanied by episodes of brief loss of muscle tone. According to DSM-4TR, the diagnostic criteria for narcolepsy is as follows. 1. Irresistible attacks of refreshing sleep that occurs daily over at least 3 months. 2. The presence of one or both of the following. Number 1, catalepsy. Or 2, recurrent intrusions of elements of rapid eye movement sleep into the transition between sleep and wakefulness, as manifested by either hypnopompic or hypnagogic hallucinations or sleep paralysis at the beginning or end of the sleep episodes. C. The disturbance is not due to the direct physiological effect of substance abuse, medication, or another general medical condition. So another disorder under the same category of dyssomnias is circadian rhythm sleep disorder. Most bodily functions follow a cycle or an internal rhythm called circadian rhythm that lasts about 24 hours. This involves persistent or recurrent sleep disruption leading to excessive sleepiness or insomnia that is due to the mismatch between the sleep-wake schedule required by a person's environment and his or her circadian sleep-wake pattern. According to DSM-4TR, the diagnostic criteria for circadian rhythm sleep disorders is as follows. A. A persistent or recurrent pattern of sleep disruption leading to excessive sleepiness or insomnia that is due to the mismatch between the sleep-wake schedule required by a person's environment and his or her circadian sleep-wake pattern. B. The sleep disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. C. The disturbance does not occur exclusively during the course of another sleep disorder or other mental disorder. D. The disturbance is not due to the direct physiological effect of substance or a general medical condition. Delayed sleep phase type. This type involves persistent pattern of late sleep onset and late awakening times with an inability to fall asleep and awaken at the desired earlier time. Jet lag type. Sleepiness and alertness that occur in inappropriate time of the day relative to local time occurring after repeated travel across more than one time zone. Shift work type. Insomnia during the major sleep period or excessive sleepiness during the major wake period associated with night shift work or frequently changing shift work. Now we have another category which is called dyssomnia not otherwise specified. 1. Periodic limb movement syndrome. It is also known as nocturnal myoclonus and consists of highly stereotyped abrupt contractions of certain leg muscles during sleep, such as extension of toes, flexion of ankles and knee. 2. Restless leg syndrome. It is also known as Ekbom syndrome and it is an uncomfortable subjective sensation of the limbs, mostly legs, often described as creepy crawly sensation. The word parasomnia literally means around sleep and signifies that abnormal behaviors involving partial or incomplete arousals occur around the boundary between the wakefulness and sleep. DSM-5 characterizes abnormal behavior patterns associated with partial or incomplete arousals as parasomnias. A category of sleep-wake disorders that is further divided into disorders associated with REM sleep and those associated with non-REM sleep. The first category we have is rapid eye movement sleep behavior disorders, or they are also known as an abbreviation of RBD. RBD involves repeated episodes of acting out one's dream during REM sleep in form of vocalizing parts of the dream or thrashing about. In cases of REM sleep behavior disorders, muscle paralysis is absent or incomplete, and the person may suddenly kick or flail the arms during REM sleep, potentially causing injuries to the self or the bed partner. Next is nightmare disorder. People with nightmare disorder have recurrent episodes of very disturbing and well-remembered nightmares during REM sleep. According to DSM-4TR, the diagnostic criteria for nightmare disorder is as follows. A. Repeated awakenings from the major sleep period or naps with detailed recall of extended and extremely frightening dreams, usually involving threats to survival, security, or self-esteem. The awakening generally occurs during the second half of the sleep period. B. On awakening from the frightening dreams, the person rapidly becomes oriented and alert. C. The dream experience or the sleep disturbance resulting from the awakening causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. D. The nightmares do not occur exclusively during the course of another mental disorder. Next is sleep terrors. Sleep terrors are characterized by repeated episodes of terrors, including arousals, that usually begin with the panicky scream. According to DSM-4TR, the diagnostic criteria for sleep terror is as follows. A. Recurrent episodes of abrupt awakening from sleep, usually occurring during the first third of the major sleep episode and beginning with the panicky scream. B. Intense fear and signs of autonomic arousal such as tachycardia, rapid breathing, and sweating during each episode. C. Relative unresponsiveness to efforts of others to comfort the person during the episode. D. No detailed dream is recalled and there is amnesia for the episode. E. The episodes cause clinically significant distress or impairment in social, occupational, or other important functioning. F. The disturbance is not due to the direct physiological effects of a substance or a general medical condition. Next disorder is sleepwalking disorder or somnambulism. It consists of sequence of complex behaviors that are initiated in the first third of the night during non-REM sleep in stage 3 and stage 4. In sleepwalking, people who are sleeping have repeated episodes in which they walk about the house while remaining asleep. During these episodes, the person is partially awake and can perform complex motor responses such as getting out of bed and walking into another room without full consciousness, and later memory of the episode. According to DSM-4TR, diagnostic criteria for sleepwalking disorder is as follows. A. Repeated episodes of rising from bed during sleep and walking about, usually occurring during the first third of the major sleep episode. B. While sleepwalking, the person has a blank staring face, is relatively unresponsive to the efforts of others to communicate with them, and can be awakened only with great difficulty. C. On awakening, the person has amnesia for the episode. D. Within several minutes after awakening from the sleepwalking episode, there is no impairment in mental activity or behavior. E. The sleepwalking causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. F. The disturbance is not due to the direct physiological effects of a substance or a general medical condition. Parasomnia is not otherwise specified. A. Sleep-related bruxism. This is tooth grinding that occurs throughout night and most prominently in stage 2 of sleep cycle. B. REM sleep behavior disorder. It is characterized by episodes of complex, generally violent behavior that is like acting out the dream. C. Sleep talking, that's somniloquy. It is very common in children and adults and can be found in all stages of sleep. It includes a few words that are difficult to distinguish. D. Sleep-related head banging. That's also called jictatio capitis nocturna. It can be generally seen in form of head rocking or full body rocking occurring just before or during sleep. E. Sleep paralysis. It is characterized by sudden inability to execute voluntary movements just at the onset or on awakening, during night or in the evening. Now you must know about the epidemiology of sleep disorders. First, we must know the prevalence. Approximately 1/3 of the population have sleep disorders at some point in their lives. Between 20% and 40% of adults report difficulty sleeping at some point each year, and about 17% of adults consider the problem to be serious. Sleep disorders are a common reason for patient visits throughout medicine. Approximately 1/3 of adults have insufficient sleep syndrome. 20% of adults report chronic insomnia. So we move on to age-related demographics. Increasing age predisposes to sleep disorders. 5% incidence in persons aged 30 to 50 years and 30% in those aged 50 years or older. People who are elderly experience a decrease in total sleep time with more frequent awakenings during the night. Elderly persons also have a higher incidence of general medical condition and are more likely to be taking medication that cause sleep disruption. People who are elderly may have widespread or multi-site pain that is associated with sleep difficulty. According to the Maintenance of the Balance, Independent Living, Intellect and Zest in Elderly study. Sex-related demographics. Primary insomnia is more common in women with the female to male ratio of 3:2. Hormonal variations during the menstrual cycle or during menopause may cause disruption in sleep. Obstructive sleep apnea or OSA is more common in men, that is 4%, than in women, that is 2.5%. Prognosis. The prognosis varies widely depending on the cause of the insomnia or other sleep disorders. For example, insomnia due to refractory major depression is itself refractory until successful treatment can be found for the depression. Now we must discuss the treatment modalities available for sleep disorders. The most common method for treating sleep-wake disorder is the use of sleep medications. However, because of problems associated with these drugs, non-pharmacological treatment approaches, principally CBT, has come to the fore. First, we will discuss the biological approaches. Anti-anxiety drugs like benzodiazepines and zolpidem, stimulant drugs and antidepressants are often used to treat sleep disorders like insomnia, narcolepsy, somnia, deep sleep disorders, etc. Sleep medication primarily work by increasing the activity of GABA, a neurotransmitter that dampens the activity of central nervous system. Despite their benefits, sleep medications have significant drawbacks. They tend to suppress REM sleep, which may interfere with some of the restorative functions of sleep. They can also lead to a carryover or hangover of the following day, which is associated with the daytime sleepiness and reduced performance. These drugs quickly lose their effectiveness at a given dosage level, so progressively larger doses must be used to achieve the same effect. High doses can be dangerous, especially if they are mixed with alcoholic beverages at bedtime. Sleep medications can also produce chemical dependence if used regularly over time and can lead to tolerance. Some side effects of such drugs include agitation, tremors, nausea, headaches, and in severe cases, delusions or hallucinations. Users can also become psychologically dependent on sleeping pills. Thus, the aim of treatment should be to provide a temporary respite so that the therapist can help the client find more effective ways of handling sources of stress and anxiety that might contribute to sleep disorders. The first line treatment for sleep apnea is the use of mechanical devices that help maintain breathing during sleep by keeping the upper airway passage open. Surgery may be required to widen the upper airways in some cases to ease the breathing and release obstruction. Now we have some psychological approaches to deal with the sleep disorders, wherein by and large being limited to the treatment of primary insomnia. Cognitive behavioral techniques are short-term in emphasis and focus on lowering bodily arousal, establishing regular sleep habits, and replacing anxiety-producing thoughts with more adaptive thoughts. Cognitive behavioral therapists typically use the combination of techniques including stimulus control, adopting a regular sleep-wake cycle, relaxation training, and rational restructuring. CBT has become the treatment of choice for insomnia, which yields substantial therapeutic benefits as measured by reduction in time it takes to get to sleep and by improved sleep quality. It also produces better results in a long term than sleep medication. Next way to improve this is sleep hygiene. Sleep hygiene is the controlling of all behavioral and environmental factors that precede sleep and may interfere with the sleep. It is the practice of guidelines in an attempt to ensure more restful, effective sleep, which can promote daytime alertness and help treat or avoid specific kinds of sleep disorders. Trouble sleeping and daytime sleepiness can be indication of poor sleep hygiene or sleep habits. Educating patients in good sleep hygiene is the keystone of treatment. The following advice should be given to the patient, and these instructions include: use the bed for sleep and sex only, no television watching or reading in bed, avoid caffeine especially late in the day, avoid activities that will get you stimulated and upset late in the day, practice relaxation technique before bedtime, exercise each day, maintain a regular schedule for bedtime and wakening, avoid naps, do not watch the clock while in bed, avoid struggling to fall asleep in bed, instead get up and spend quiet time out of bed until sleep comes. Other interventions that are available to treat sleep disorders are as follows. Sleep apnea can be alleviated by losing weight, the use of continuous positive airway pressure, and sometimes surgical treatment. Light phase shift therapy is useful for sleep disturbances associated with circadian rhythm abnormalities. Variety of software programs are commercially available that use wristbands or motion detection technology embedded in smartphones to identify and record the patient's sleep cycles and behavior. Patients should avoid sleep disturbing substances such as alcohol, nicotine, and caffeine. Alcohol creates the illusion of good sleep, but it adversely affects sleep architecture. Nicotine and caffeine are stimulating and should be avoided in the second half of the day, from late afternoon on. Consumption of tryptophan containing foods may help induce sleep. The classic example is warm milk. Strenuous exercise during the day may promote better sleep, but this same exercise during 3 hours before bedtime can cause initial insomnia. Stimulating activities should be avoided 3 hours before bedtime. Now we come to the summary of this chapter. A sleep disorder or somnopathy is a medical disorder of the sleep patterns of a person or animal. A formal assessment of sleep disorders is achieved by polysomnographic evaluation. Two of the major types of primary sleep disorders are dyssomnias and parasomnias. Sleep disorders are listed among the clinical syndromes in Axis 1 of the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders. The most common method for treating sleep-wake disorder is the use of sleep medications. However, use of these drugs should be time limited because of the potential for psychological and physical dependence, among other problems. Cognitive behavioral interventions have emerged as the treatment of choice for producing substantial benefits in helping people with chronic insomnia.